An 87-year-old female was admitted with right upper quadrant abdominal pain. Clinical, laboratory, and imaging characteristics were suggestive of small stones in the distal bile duct that was uniformly dilated. No stones were seen in the gallbladder. At EUS examination, a dilated bile duct was visualized with a small floating stone measuring 7 mm in size. No stones were seen in the distal bile duct at the ampullary orifice. Although not definitive and certainly debatable, the possibility of a foramen-frust choledochal cyst based only on EUS examination was entertained. At ERCP, the major papilla was identified at the lip of a diverticulum. A pancreatogram was obtained and a 4 French by 9 cm prophylactic pancreatic stent was placed to facilitate bile duct cannulation. Multiple attempts at biliary access using a standard sphinctertome and a taper-tip cannula failed. Subsequently, a small-sized transpapillary sphincterotomy was performed, followed by multiple unsuccessful attempts at deep cannulation of the bile duct. What is the next best step in management? 1. Eus-guided rendezvous drainage via the extrahepatic bile duct. 2. Eus-guided rendezvous drainage via the intrahepatic bile duct. 3. Percutaneous transhepatic biliary drain placement followed by stone extraction. 4. Laparoscopic common bile duct exploration at cholecystectomy. While the tight ampullary orifice at ERCP was indirectly suggestive of possible foramen-frust choledochal cyst, in this particular patient, we decided to pursue EUS for rendezvous access to the common bile duct. The extrahepatic bile duct was punctured in a long scope position using a 19-gauge FNA needle. Note that on the cholangiogram, the pancreatic duct was opacified, suggestive of an anomalous pancreaticobiliary junction. Despite numerous attempts using a straight and curved tip 0.025-inch guide wire, the papilla could not be traversed. Additionally, every attempt at guide wire manipulation dislodged the FNA needle and resulted in a submucosal injection. Please note the significant submucosal injection on endoscopic view at the ampullary orifice. The guide wire eventually became trapped at the needle tip, and for the fear of shearing the wire, the echoendoscope was removed along with the needle assembly. What is the next best step in management? 1. Perform a choledochoduodenostomy. 2. Percutaneous transhepatic biliary drain placement followed by stone extraction. 3. Laparoscopic common bile duct exploration at cholecystectomy. Or 4. Repeat the ERCP in 24 hours. Given that the bile duct had already been punctured, and due to the likelihood of significant bile leak and pain, an emergent consult was requested with interventional radiology, and the patient was transferred while remaining intubated. At percutaneous transhepatic cholangiography, the guide wire would not traverse the major duodenal papilla. Note that on every attempt at guide wire manipulation, despite the presence of a pancreatic stent, a pancreatogram was obtained. Also, no bile leak was seen, likely because the submucosal injection sealed the site of bile duct puncture. Following the placement of a stiff catheter in the common bile duct, a microwire was successfully advanced via the major duodenal papilla, and an internal-external biliary drain was placed successfully. The patient recovered uneventfully and was scheduled for an elective ERCP for definitive stone extraction. These are the take-home points from this case. A foramen-frust choledochal cyst is a poorly described entity where the common bile duct is only marginally dilated and hence not recognized easily. There is almost a 100% association with anomalous pancreaticobiliary junction. Due to constant reflux of pancreatic juice, there is risk for biliary malignancy over time. Also, due to constant reflux of pancreatic juice and a tight ampullary orifice, bile duct stone formation is common. The tips for diagnosing a four-may-fruit colorectal cyst are a floating common bile duct stone in the absence of a stone at the ampullary orifice, the absence of gallstones, a uniformly dilated bile duct measuring 10 mm in diameter, the presence of an anomalous pancreatic biliary junction, and failed common bile duct cannulation. Serious adverse events at ERCP can occur when treating patients with four-may-fruit colorectal cysts. Failed bile duct cannulation in the absence of prophylactic pancreatic stent oftentimes result in severe necrotizing pancreatitis. Therefore, heightened clinical awareness based on the diagnostic clues presented earlier is important. The tightness of the ampullary orifice can preclude guide wire passage at Eus-Guided rendezvous drainage, even when performed in expert centers. Pursuing further aggressive attempts is likely futile. Adverse events are sometimes inevitable and always not preventable in clinical endoscopic practice. Therefore, it is important to collaborate closely with multidisciplinary colleagues to achieve the best optimal outcomes for patients.
On behalf of the entire team of the Orlando Health Digestive Health Institute and our Center for Advanced Endoscopy Research and Education, we extend a warm invitation to join us on August 20 through 22 in Orlando for Florida Live Endoscopy 2026. This will be a unique meeting where we will celebrate the accomplishments of a generation of endoscopists while exploring the future of endoscopy. This will not be just another endoscopy conference, but rather will be a unique and lively gathering that spans generations, highlighting pioneering techniques and innovative breakthroughs. Prepare for a fascinating journey through the evolution of endoscopy. You will experience live demonstrations of the latest procedures, connect with renowned experts worldwide, and gain valuable insights from leaders who have shaped our field. Discover the expertise of 20 renowned international faculty members whose remarkable insights will elevate your learning experience. Celebrate the legacy of endoscopic pioneers and witness the future of endoscopy unfold. Register today and become part of this remarkable journey, where tradition meets innovation in the continuous evolution of endoscopy. Save the date for Florida Live Endoscopy 2026, the premier event showcasing history, excellence, and upcoming advances in endoscopy. Florida Live Endoscopy 2026, where the magic of endoscopy begins.